Among pleural effusions that present as complex septated and loculated patterns, as complex non-septated and relatively hyperechoic pattern, or as homogeneously echogenic pattern, the incidence of diagnostic empyema in febrile medical ICU patient was found to be up to 43%. This contrasts with the anechoic or complex non-septated and relatively non-hyperechoic pattern of effusions for which no infection was documented in that same study. These findings demonstrate how important it is to adequately characterize a pleural effusion when the potential diagnosis of empyema is considered. These findings suggest that, in the presence of a pleural effusion in a febrile patient, the following approach should be considered. If anechoic or complex non-septated and relatively non-hyperechoic sonographic effusion patterns are encountered, the chances that the effusion is infected is low, and drainage or tap should be performed only if the ventilation and/or oxygenation is problematic because of the effusion. If the effusion pattern is complex septated, loculated, or homogeneously echogenic, the chances that the effusion is infected is higher, and intervention in the form of a simple tap or drainage to diagnose a potential empyema should be aggressively pursued. Sequential follow-up sonography will often be necessary in those patients with persistent fever who initially had an effusion with low-risk characteristics.